Thanks for being here this morning for what promises to be another interesting and entertaining session this morning. Before we get too far, I would like to share a reflection. This is a personal favorite of mine. It's actually one that I stumbled upon in my early days, as a young athlete, and it's been a go-to for me easily for 25 years, so I wanted to share it with you this morning. It's called Just Do Your Best. Just do your best in whatever you do, though sometimes it may not be easy for you. Half-heartedness never accomplished a goal, and positive thinking is food for the soul. Just do your best, that's all one can ask, in spite of the odds, whatever the task. So what if you work up some old-fashioned sweat? You first have to give before you can get. Just do your best with what you have got, and though it's a little, or if it's a lot, you'll know in your heart when each day is through, you've done everything God's expected of you. Today's topic is a little bit different than what you've seen in the past from No and Go Fridays, but it's one that's very important to ensuring the overall quality and accuracy of the work that we do here within Agnesian HealthCare. As you know, we've committed as a system significant resources, both financial and human resources, toward the introduction of electronic health records here at Agnesian HealthCare. So we thought it was important enough to bring Dr. Joseph forward to talk about what CPOM is and what that means to our system. So Dr. Joseph is our Chief Medical Information Officer, and he's going to share with us why it is so important and how CPOM can actually enhance patient care. But before we do that, we have a little video for you.
You've been there, trying to read the doctor's orders. Unclear, hard to read, shift change, patient alarm rings. Stop! There is something better. CPOM, computerized physician order management, is here, and it goes something like this.
I hear the doctors coming, they're coming round the bend. They ain't seen nothing like this, so CPOM, well, we're out of paper prison, and we're moving fine. CPOM keeps on rolling, you better get in line. When I was just an intern, my teachers told me learn to write your orders clearly, 'cause cursive is no good. Computers help me chart and communicate. Oh, the patient care is better and the nursing's great. Technology is where it's at. I can't remember when. It'd take all day to get this done now. I'm done by 10 and I'm on the golf course swinging. They're not paging me. CPOM is my buddy. Yippee technology. CPOM is where it's at. It makes our lives a breeze. We're working more efficiently. Our patients are so pleased, and Elmer sure is easy, and it works for me. CPOM is my buddy. Yippee technology.
Without further ado, Dr. Joseph.
All right. My name is Craig Joseph. I'm the Chief Medical Information Officer here at Agnesian. I am, without doubt, the best Chief Medical Information Officer that Agnesian has ever had, and that is without question, I believe. So my job really, when people ask me what do, I said my job is to try and make IT and technology work for physicians and nurses and anyone that's clinical. So that's what I try and do. So here I am today to talk about CPOM. I do not have a robot. I was asked to bring a robot by Holly, but I don't have a robot. So we do have these audience response. Has anyone used these before? If you've used them, oh, a few. All right, let's see how they work. Let's go to the next slide. Okay, this is your first question. You answer 1 through 4. So while you're looking at it, we are recording who's answering. If you answer wrong, your supervisor will be informed by email. No stress, no pressure. All right, we have 75 out, 40 of you have already answered. It's pretty straightforward. What does CPOM stand for? Polling's still open. Some of you haven't figured out how to use it. Got another 10 or so. All right. So I think we're good enough. Let's go on. Now let's see. Whoa. So 5% of you are right. 94% of you are wrong. So CPOM stands for Computerized Physician Order Management. That's excellent. Let's move on to the next slide. So, pretty easy. You might have often heard of CPOM called CPOE. That's pretty standard language, although I think it's changing. The reason we went with management instead of entry is that physicians and providers are doing a lot more than just entering the orders. We're actually managing the orders. So, any new orders would be going in with CPOM by the physician or provider entering them. They modify those orders. Currently on paper, if you want to discontinue an order, what do? It's not a trick question. You write DC order, right? Hello? It's working? Okay. You write DC order. Now you're actually just going to go to the order. Physicians and providers would just go to the order. We're trying essentially to remove paper from the process of ordering and discontinuing and modifying medications and labs and x-rays and consults and that kind of thing, all right? I didn't mention before, I am totally open to you all asking questions during this presentation. So if I say something that's confusing or you want to disagree with me, just raise your hand. Or just shout out. If you're in the back, throw something, that'll work. All right, that's what CPOM is. Let's go to the next slide. What's an order? And it's interesting to think about what an order is because it sounds rather straightforward, but in the IT world, we have to break everything up into little buckets. So here are some of the buckets. There are inpatient and outpatient orders. That seems fairly straightforward, right? And there are meds and not meds. Sometimes in the IT world, we call not meds procedures. That's just our little term for it. So let's talk about outpatient. We're already live with order entry, order modification, CPOM, in the outpatient world in our clinics. We're doing e-prescribing. So if we want to send a prescription for Lipitor to Walgreens, that's an outpatient order. Amoxicillin to CVS, give a flu shot, those are all outpatient orders. So you can see we're pretty much outpatient medication orders. We're already live with CPOM 1 out of 4 in 1 out of 4 areas. We're not live in the outpatient for tests and procedures. So x-rays, labs, those kinds of things, we're not live yet. On the inpatient side, for medications, we do the same kinds of meds. We do the Lipitors, we do the amoxicillins, but for anyone that works in a hospital, you must know that the medications that we use on the inpatient side tend to be a little bit more complicated. All right, so a dopamine or a dobutamine, a very difficult IV medication is also going to be needed, which we're not really doing on the outpatient side. On the inpatient side, we'll also be doing the labs and the x-rays and the consults and those kinds of things. So when I say order, this is what I want you to be thinking of. Inpatient and outpatient, medications and not medications. All right, next slide. So stop, start, and continue. If any of you have been involved with our workflow analysis that we've been doing on the IT side, when we go live with CPOM, and I'll talk about this more in a future slide, we're going to stop doing some things, we're going to start doing some other things, and we're going to continue doing a bunch of things. So what are we going to stop doing? For the most part, We're going to stop using handwritten paper orders, for the most part. There will be islands here and there that we're not going to be able to eliminate on the first pass, but eventually that's where we're going to stop that. We're going to stop doing paper medication reconciliation. What is medication reconciliation? That's when we look at the meds that we think you're on and talk with you about it to make sure that that med list is as correct as possible. So medication reconciliation occurs whenever we change venues, whenever we go from the emergency department to the floor, from the floor to the ICU, from the ICU back to the floor. We're always going to be looking at your meds and making sure that our list is as proper as it can be. Today we do this on paper in our hospitals, except as discharge. We're doing that in the computer. We're going to move that to all being done in the computer. What are we going to start doing? We're going to start entering our orders and modifying our orders, physicians and providers and nurses who are putting orders in on behalf of doctors. We're going to start doing that in the computer. We're going to limit the use of phone orders, and we'll talk about that a little bit more. I already talked about electronic med rec. The discharge process, we're going to be adding some things. So right now, physicians and providers write down the follow-up information, when the patient should follow up, what kind of diet, what kind of activity restrictions. Those are all written on paper. We're going to be moving that into the computer. We're also going to be working on the problem list or the diagnosis list from the inpatient side as well. We need that problem list, the list of issues that we're dealing with the patient, to be as up-to-date and current as possible and accurate as possible. Let's go on to the next slide. We're going to talk about what continues. So a lot of things don't change when we go live with CPOM this fall. We're going to still look at all of our results in Elmer, and Elmer's our name for all the IT that we use. We're going to continue to talk to people. So I think our plan is not to get rid of the phone for about a month. A month after go live, we will remove the phones from the unit. Okay, that's false. That's just a test to see if you're there. No, the phones remain. And so we'll talk more about communication later. We need to make sure that we're putting orders on the right chart. That's pretty easy to do. Make that mistake. We don't want to do that. And we're going to be continuing to utilize Message Center. So these are all the things that we're already doing today. We're going to continue doing this. Questions so far? You're afraid to ask questions. All right, I'll start to say some controversial things and see if anyone stops me. Let's go on to the next slide. Who does this affect? Well, it affects anyone that enters orders right now. Anyone that's an authorized or ordering provider. Physicians, nurse practitioners, physician assistants. But it also affects anyone who I didn't put on the slide who can take those orders verbally or over a telephone. So because instead of writing those things down, nurses are going to be entering that. Technicians that are allowed to take verbal orders, telephone orders, are also going to be entering those in the computer. So there's going to need to be some training that's going to happen probably. Next slide. Where is this happening? There's the list. Apparently there are 3 hospitals, I'm told. Is that accurate? 3 hospitals that are within our Agnesian family. So St. Agnes, Waupun, and Ripon. Fond du Lac Surgery Center. Any Fond du Lac Regional Clinic office. And consultants lab. So are we going out into our private doctors' offices and telling them that they have to get rid of their paper? We are not. So this is pretty big, but this is only affecting within our walls. Does that make sense? Okay, good. All right, next slide. When is it happening? Notice I put the times. We expect all of you to be here because we can't go live without you. So we expect all of you to be here. So we're doing this in 3 stages. Stage 1 is September, and it's going to be Waupun and any clinics that are geographically near Waupun. Okay? We just did it from a geographic standpoint. So clearly the ones that are connected, but anything near Waupun is going to go live on Sunday, September 22nd. October 20th, that's going to be our big one. That's here. And apparently we have a big clinic over there somewhere. Those are all going to be going live in October. That's going to be big. And then November will be Ripon. Now, you might ask, how did we decide this? And I know Waupun's listening. Watch out. Sometimes you get what you ask for. So Waupun said, boy, we think we can be successful. We want to go early. And we said, okay. So that's what happened. So watch out. Sometimes you get what you ask for. Let's go to the next slide. When is dialysis going live? I don't know off the top of my head. That was not the kind of question that I was expecting to get. If someone asked me, what's 263 times 412? I'm not going to get that answer. So we'll get that for you, Heather. All right, so what's going live? Here are the list of clinics. hopefully you've seen this. Hopefully this is not news to you. These are the actual clinics that are going live at Waupun. Let's go to the next slide. These are the clinics that are going live at St. Agnes in October. So this is going to be our big one. And then the next slide is Ripon. And that should be all of the clinics. There are going to be a few that aren't listed in their dialysis. One thing you might notice, Agnesian Cancer Center, even though they're here, they're in multiple places. We're going to have them go live in stage 3 in November. You might have also noticed that Convenient Care, even though that's located in Fond du Lac, is going to be going live very beginning with Waupun. So our rules are not 100%, but that's the list. Okay, let's go over this. Next. We're going live this year. Next one. That's 2013. Next one. That's in a few months. Last one. I know, right? So, from an IT standpoint, it seems like it's tomorrow we're going live. So, there's a ton of work that's gone into this, you heard Holly say, and there's a ton of work that's ongoing, and there'll be a ton of work when we go live. But it is going to happen September for Waupun, October for Fond du Lac, November for Ripon. All right, next slide. Here we go. Question number 2. Why do you all think that we are moving to CPOM? There are your choices. Remember, we know who you are. Some of you did not do well on the first question. All right, ooh, much faster now. We've got over 60, 65. All right, let's go and see what you said. Why are we moving? Again, it's the same, I know it's the same people. All right, CPOM helps us improve care. That's the reason we're doing it. We're not doing it for any other reason. We're trying to improve care of the patient. Personally, I like number 3. I see probably one of you voted for that. I'm assuming that's a physician. I'm looking in the back there. And, you know, again, having hucks enjoy all the time is probably not the right answer. Okay, next one. So CPOM can improve care. I didn't say it will improve care. It can improve care. How? Well, certainly we're going to be eliminating transcription errors. The doctor writes one thing, and the unit clerk or nurse enters a different thing. Maybe it was a mistake, maybe it was poor, it was inability to read it, lots of different reasons. We can eliminate delays while we're moving paper. We're not moving any paper, right? So the second that order gets typed in and validated by the physician or nurse practitioner or PA, it's an active order and it can be initiated. Real-time clinical decision support. That's the one that I'm most excited about. That's going to take some time for us to actually get going, but the potential is there, and it's really quite amazing. Most of you know about clinical decision support from kind of things like allergy checking. So you put in an order for, or a physician puts in an order for amoxicillin and it gets a pop-up saying the patient's allergic to amoxicillin. This is probably the wrong antibiotic to choose. That's clinical decision support. But better clinical decision support is you ordered this antibiotic and the patient has pneumonia and this antibiotic doesn't typically work with the sputum sample that we got. Might you want to consider a different antibiotic? That's pretty exciting stuff, the ability to do that. Doctors and nurse practitioners and PAs will actually enjoy getting those kinds of alerts because it'll change what they're going to do. But to get that to work, we need the problem list up to date. You heard me mention the problem list before. I need to know that you've got pneumonia. I need to know that we've done a sputum sample on you, and I need to get those results from the lab to know what the organism is and to make sure that the antibiotic that we're using works on that organism. That's clinical decision support, and that's coming. And that will only work if we're entering our orders into the system ourselves. Writing them on paper is not going to work. Alerting the unit clerk that that might be the wrong antibiotic is probably not a good outcome long term. Ordering can happen anywhere at any time. So theoretically, our physicians can enter orders in Hawaii if they so desire. Probably not a good idea if you're managing a patient in the ICU. But a fine idea if a patient calls and needs a lab ordered. You can do that anywhere you want. You don't need to be here to actually do that. So, you know, I need to check my anemia and get a hemoglobin done. Doctors or nurse practitioners can do that from anywhere. CPOM is becoming the standard of care. By that, I mean, it was one of the choices in the previous answer. Everyone's doing it. if you think about the hospitals and clinics around us, it's hard to come up with a hospital that's not either live with CPOM or about to be live with CPOM or has a date for a go live for CPOM. It's the standard of care. And so we're doing it to help improve care, but it is true and accurate that everyone around us is doing it. So I have had physicians in the past say, well, I'm just going to move from this hospital and go to that hospital where they're not doing it. Good luck with that. That's not going to last very long. Payers are rewarding right now hospitals and doctors that use CPOM because they know it helps improve the standard of care. Payers do this thing. First they say, we'd like you to do this. Then they say, we're going to reward you for doing this. And then they say, you know what's coming next? What's coming next? You have to do this, right? And you might say, well, insurance companies, they can't force us to do anything. That is true, but they can say, we're going to pay you less than we pay that guy over there if you're not doing what we want you to do. Or we're just not going to send our patients to you. So this is coming. Next slide. All right, we talked about patient safety. We talked about improving care. I know if there are nurses in the front row, you can read this. I actually think that says Reglan. That is not a good thing, right? And that's what happens now. And I remember as a resident, nurses coming up to me and saying, can you tell us what your colleague just wrote? And sometimes I could, sometimes I just make it up, but mostly nurses figured it out better than I could, right? This is bad. This is where we're moving to, and I know you can't see it, but it's all pristinely presented, right? There's no question about what the doctor intended. Now, could the doctor order something wrong? Sure. I mean, that can always happen. You could do that out. You could order the wrong thing on paper. You could order the wrong thing in Elmer, in our Cerner system. But it's very clear the intention, and that's part of the reason that CPOM has been shown to be successful and why we're doing it. Next slide. Okay, I mentioned clinical decision support. Only possible with real-time ordering, and I really want to emphasize this because this is going to be a huge benefit to our ordering physicians and to our patients because of that. It leads to improved care. I did mention it requires a complete electronic health record. So sometimes you might not see the reason that you're doing things, right? You might say, well, we never ordered a referral before. Let's talk about a consult in the inpatient side. Right now, sometimes doctors order a consult. They'll write down consult, cardiology. They're required to talk to the physician, so they'll pick up the phone and call the cardiologist that they want or the cardiologist that's on call. And sometimes that gets documented in their note, and sometimes it doesn't. And we're going to be asking doctors to put those consult orders in. Because it's really an order, right? Consult cardiology, that's an order. Why is that important? Why would we ask doctors to do that? Well, wouldn't it be nice if we were consulting cardiology that the whole team that was taking care of the patient knew that we were consulting cardiology? Wouldn't it be nice to be able to send a little reminder to a unit clerk or to a nurse saying, hey, it looks like cardiology was consulted 24 hours ago, and there doesn't seem to be a note from the cardiologist on the chart. Might you want to look into that? That's really helpful to the patient. That's really helpful to the cardiologist. That's really helpful to the ordering physician. All right? So there are some times that we really need the EHR to be complete, and you may not see the benefit of it. The doctor may not see the benefit of some of these things in the short run. Certainly we'll see them in the long run. So I want you to think about the big picture sometimes instead of just what's in front of you now. And again, clinical decision support needs to hit the sweet spot. What I'm talking about is no one wants to be reminded of something they're about to do, right? You don't want to, when you wake up and your alarm clock goes off, you don't want to be reminded you need to take a shower. You're like, yes, I was going to do that. Thank you so much. That's not helpful. That's just annoying. So we don't want to annoy our ordering providers. We want to help them. Really what I'm looking for when I look for clinical decision support, I say to myself, will this change what the doctor was going to do? Will this pop up? Will this reminder? Will this alert change what you were going to do? If the answer is yeah, then that's a really good alert. If the answer was almost never, then that's probably not a very good alert. Was there a question? No. Okay. Any questions about CPOM, clinical decision support so far? No. All right, next slide. What are the kinds of clinical decision support? Well, there are order sets, and you might say, well, we have order sets now. How is that clinical decision support? Well, one of the hallmarks of a good electronic health record and CPOM system is the ability to make it easy to do the right thing. We want to make it easy for our doctors and nurse practitioners and PAs to do the right thing. And what's the corollary of that? make it a little more difficult to do the wrong thing, right? Sometimes it's confusing, and sometimes there's debate about what the right thing is and what the wrong thing is among physicians, right? You get 2 physicians, you have 3 opinions. I get that. But order sets put all the orders that our system as a whole thinks are a good way of treating X diagnosis. So community-acquired pneumonia. Here are the antibiotics that we think as an organization, this is not coming from outside, this is us, think are good antibiotics for this. Here are the orders that we think are typically used after a knee arthroscopy, after a knee surgery. So make it easy to get those orders in because those are the right things to do. That's a form of clinical decision support. We talked about alerts. Formularies are the medications that we have either on the outpatient side. Formularies are medications that are covered by your insurance company. That's a good thing. We'd like to order meds that are covered by your insurance company and not order meds that aren't. Inside the hospital, formularies are the list. It's just really the list of medications that we have available. And I mentioned already, we want to make it easy to do the right thing. Let's talk about some of these in more detail. An order set. In the Cerner world or the Elmer world, we don't want to call it an order set. We call it a power plan. It's the same thing though, right? It's a list of orders, and I check the ones I want, all right? It's easy to do the right thing. Some of these things will default in, meaning the second that the doctor orders it, it's going to be right there checked. So if you and doctors can save these as a favorite, as their favorite form. So what doctors can do is say, well, I typically do a physical therapy evaluation. I always do it. So they can save this so that when they open it up, it's already pre-checked. And what I normally tell doctors is for things that you do routinely, it's impossible for you to do them faster on paper than I can do them in the electronic health record. For things you do routinely. These are order sets. Next one, alerts. So this is a fairly advanced alert, but one of the tools that Cerner offers us is the ability to do some of these things. So Cerner in the background can be looking at the patient and come up with a potential diagnosis to say, hey, this patient that you think is kind of stable has a low blood pressure, and the blood pressure has been trending down, and the temperature seems to be going up, and the last 3 white counts have been going up, implying that there's an infection somewhere that's not being treated properly. And you might notice that when the patient, stops breathing or crashes. Wouldn't it be nice to notice that 12 hours prior? These are some tools that are impossible to use without an electronic health record. You can't do it with paper. You can't do it with CPOM. You can only do this if you're actively, our physicians are actively in the system and looking at the orders and seeing what's going on. And having a helpful guide behind the scenes is a form of clinical decision support that we absolutely want to leverage. Will all of these things be there in September when we go live? Absolutely not. All right? For the main reason that I told you, we don't want to over alert our physicians. They get something called alert fatigue. You might have already gotten it if you've seen any of these. If you've worked with computers and constantly get a pop-up that tells you something that you don't care about. Your virus scan is out of date. Yeah, whatever. Okay. Click through it, You don't know what it says. That's alert fatigue. We really want to avoid that. We want our doctors and nurse practitioners and PAs looking at these things and saying, okay, yeah, that makes it. I see that, I'm not worried about it. Or, wow, yeah, I didn't realize that. Thanks for calling that to my attention. Alerts. And the last one is formularies. So we're able to say, boy, the patient came in on one medication for reflux disease, but we don't have that in our hospital. Wouldn't it be nice to automatically tell the doc, hey, we're just going to change it from this medication to that medication with your permission. And when the patient goes home, by the way, we're going to automatically recommend that you discontinue the medication that we started in the hospital and send them back home on their med that's been working at home. We just don't carry that. Very hard to do on paper, almost impossible, but we're going to be doing that with clinical decision support inside Cerner. Okay. All right. Mentioned, I just wanted to kind of give you a few examples, not trying to train anyone on anything. But boy, if you're adding an order and you see Nexium with a red triangle next to it, it's a hint to the physician that you can order Nexium, but you're not going to get Nexium. In the hospital, you're going to get Protonix. Works very similarly in the outpatient side if we have formulary information from the insurance company. Hey, doctor, you're going to prescribe this medication. It's going to cost the patient, when they show up at the pharmacy, $75. Here are some that are going to cost $20. Now, maybe they need that $75 medicine. Maybe one of those $20 medicines are going to work. And remember, the very next patient, it could be reversed because their insurance company has a different formulary. So it's impossible for doctors to know this, and those formularies can change from year to year, from month to month. So we can keep that up. There's no way to do that by ordering with paper. Okay, moving on. Question number 3. I'll let you look at that. What is the right answer? Do you guys? All right, they're coming in fast and furious. All paper ordering will be eliminated by the end of 2013. I gave you a hint on this one. I feel like as we go, I should just give you more and more hints. All right, let's see what we got. So what's the right answer? False. All right, so false. Anytime, just give you a hint, anytime I ask you an all or every question, chances are that's not true. So that might help you in the future. So this is false. This is false. Are we seeking to eliminate paper from the ordering process? Yes, we are. Are we seeking to eliminate paper from the documentation process? Yes, we are. Will we do that sometime? Yes, we will. We're going to get rid of a lot of paper, but we're not going to be able to get rid of all paper by the end of this year. So when? I don't know, but we'll be working towards that. I think you're going to see a huge reduction in paper, right? 90% of that paper is going to be gone by the end of the year. That's true, but there'll still be some there. Next one.
Why can't we just go all paperless day one?
Okay, I did not accept questions from the audience. I was very specific. So let me repeat the question. I don't know who that is in the back, but let me repeat the question. Why can't we get rid of all the paper by the end of the year? And the answer is there are pockets of paper that we don't have either the time to get to with our IT infrastructure, with our project now, or we don't have the we don't have the functionality that we need from our EHR to be able to deal with that right now. So it's a little bit of both. Sometimes it's stuff that, yeah, if you gave me another 6 months, I could get rid of that paper now. Sometimes it's, you could give me a year and a half. You could give me 10 years. I don't have the functionality that we need to be able to enter that information in a simple, straightforward way. The good news about our EHR vendor is that they're always improving the software and adding functionality. The bad news is they're always improving the software and adding functionality. So when we go live, if you think that's what it's going to look like, however it's configured and however the buttons are working, if you think that's how it's going to be forever, you're sadly mistaken. It's always going to be getting, I hope, better, but it's always going to be changing. So this is the beginning, this is the first step, and this is a progress, this is an evolution, but we're going to be taking a big swipe out of it this year. Did that satisfactorily answer the question, man in the back? All right, question 5, next one. Next slide. Oh, there we are, I'm sorry, question 4. Duh. All right, let's answer this question. Come on, people. I've given you a lot of information here about where we should go. So verbal orders, you could put in telephone orders as well. A lot of people think of verbal orders and telephone orders as the same thing. Let's see what people said. All right, some of you are just being difficult. That's fine. I would do the same. I would do the same thing. So the answer is false. False. We are not attempting to eliminate 100%, get rid of verbal orders. Let's go to the next slide. And we'll talk more about verbal orders in a second. Go ahead, answer the question. We need to know what you know. Okay. Wait. I think we're probably. I bet you it's gonna be 10%, 90. Oh! See that, Steve? That's because they don't have a lot of physicians in the room. It was skewed. So I think that this is false. That's my personal answer. Let's go to the next slide. Okay. Let me hit 2 of those previous things a little bit. One is, are we looking to eliminate verbal orders? No. What about 2 years from now? Are we looking to eliminate verbal orders? No. What about 5 years from now? Are we looking to eliminate verbal orders or telephone orders? No. Verbal orders will always be appropriate at certain times, right? When might they be appropriate? So Ideas. When might a verbal order be appropriate? I'm sorry? Code heart. I'm gonna expand upon that. Patients trying to die, right? Code heart, patients trying to die. Probably not a good idea to say, well, I see that you're not breathing. Let me go and get my computer and log in. That's a bad idea, right? Shouting verbal orders and nurses running and getting meds and technicians doing whatever they need to do, probably a much better answer, right? So taking care of the patient will always trump the need. When could you imagine a telephone order being appropriate? Never. Computers down. Well, if computers down, we're going to revert to paper. When else might a telephone order be appropriate? All right, I'll take two of those. Doctor's office isn't hooked up to our CPOM. There's really not a good excuse for that. However, because even our private docs can, I'm not sure where that the answer came from, but even our private docs can get access to Cerner 24 hours a day, 7 days a week from their personal computers. So they don't need an Agnesian computer to get access. So theoretically, that's not a good one. But you're absolutely right. They're in the middle of their day. They don't have our Elmer system open because they don't typically use it. Absolutely appropriate for telephone. Over here, I heard middle of the night. I think that's another absolutely appropriate use of the telephone. You know, hey, patient's got some pain that was unexpected. We need an order for a pain med that you didn't do. You know, the right answer is probably at 3 in the morning, not, hey, we need you to go open up your computer, wait for it to boot up, and then we need you to put in your password, and then we need you to find the patient. That's probably not a good answer. Verbal or telephone order, completely appropriate. When are verbal orders not appropriate? Getting never. Ooh, again. And I see some physicians in the room, so I'm going to assume that you all are down with this thing. Verbal orders are not appropriate. Hey, can you just put this order in for me? Wink, right? Not an appropriate order. Hey, I'm kind of busy right now. Can you put this order? Not appropriate. All right, so those are some appropriate and not appropriate verbal orders. Are people all excited about this? No. Do we have policies around it? Uh-huh. Why? Because not everyone's excited about it, right? So the 3 hospitals and the Fond du Lac Regional Clinic have said these 3 things. I'm summarizing and paraphrasing. There's only one way to order at our hospitals and in our clinics, and that's electronically using CPOM in our Elmer system. Training is required of everyone, no matter how smart you are. No matter if you've done this before, you need to be trained. And you need to pass a proficiency test so that we know that you know what you need to do. Okay? So for physicians who say, well, I'm quite smart, I'm just going to skip out on the training and I'll figure it out as I go along, not going to happen. That's not going to be acceptable. So we are tracking very carefully who's coming to training when we start the training, and be working with our doctors and nurse practitioners and PAs to make sure that they are coming to train. Any questions about this? All right, next slide. I talked about all of this. In the middle of a procedure is also the one thing that we didn't bring up. So, you know, the surgeon scrubbed into a procedure. We need an order for a pain med. Well, hang on, let me break my sterile field. Patient will be fine just here. And no, that's not appropriate. So if we can't get that order from someone else, then the doctor can give that verbally, just like they do today, over the telephone. All right, next slide. Another question. Ooh, this is a trick one. You know how I know it's a trick one? It says, trick one. What's the answer? No one's answered it yet. You have to answer. You can't leave. Okay, 50, let's keep going. A few more. All right, let's go. Let's see what, now this ought to be interesting. Ooh. All right, this is an interpretation question. My answer to this question is actually, no, there are no such things as verbal orders. Next slide, and I'll explain that. There's verbal orders with readback. That's what you're picking in the communication type. If you're a nurse, that's what you're picking today. Verbal order with readback, telephone order with readback, right? I mention this because with CPOM, what's going to happen when the nurse has to put the order in, right? You can't write it down on a piece of paper now and read it back. Why not? This little thing called clinical decision support I mentioned earlier. Yeah, you might put in that order for that antibiotic or that pain med or whatever it is, and there might be a pop-up saying, hey, this is probably not the right idea, or hey, did you think about this? What is the nurse going to do? Make a clinical judgment about whether or not they should reverse the order or go back? So nurses, technicians, whoever's taking a verbal order or a telephone order, again, I'm not talking about when patient's trying to die, but in the middle of the night, you need to be on the computer when you type that order in to tell the doctor, hey, I just got this pop-up, I don't know what you want me to do with this. Do you want to continue with this order, or do you want to change it? So that read back part becomes even more important. So I want to throw that out because that's really going to be changing the way that you're working with doctors when you're taking these verbal and telephone orders. Does this mean it's going to be more of a pain to take a verbal or a telephone order for the doctor? I mean, potentially it's going to, because now the nurse can't write it on his or her scrubs or find a piece of scrap paper and write it down and read it back. That's not going to make any sense. Because if you get a pop-up, you're just going to have to get back on the phone and call that doctor 10 minutes later. All right? So, no such thing as a verbal or a telephone order. It's a verbal or telephone order with read back. Trick question. Not fair. That's right. But I'm in charge. Let's keep going. Okay. Now this one. Oh, I'm sorry. I was asked to read the question. Is it more important to take care of the patient or take care of the computer? That's the question. Answer 1, it's more important to take care of the patient. Answer 2, it's more important to take care of the computer. I know the IT folks are going for 2, but let's see what you guys chose. That's 2 IT folks that put the computer. Obviously, it's more important to take care of the patient. I just really want to emphasize that, because in training you're going to hear, don't do this, don't do that, do it this way, and that's true. All of that is true, unless the patient needs you to do something different. So if the patient is in trouble, you need to forget about that computer and deal with the patient in front of you. And I never want any nurse to say, well, I would love to take care of this patient, but I can't because whatever, the computer's down. Guess what? The computer's going to go down. I can promise you the computer's going to go down. It's going to go down unexpectedly, sometime in the next 5 years. Guarantee it, right? It always happens. Got IT folks that are getting nervous. Jennifer, sorry. It's going to happen. So we'll have backup plans, and we'll be able to revert to paper when it happens. Hopefully it'll be for a short amount of time, and we'll get it back up. But stuff is unpredictable. I haven't seen a computer system not go down yet. So always, always, always take care of the patient. We'll figure out the computer later. Next one. Okay, what's going on with our go live? You saw that we're doing 3 go lives. We are reducing our clinic schedules. Again, I'm talking about the Fond du Lac Regional Clinic. I'm not talking about our private doctors. Why? Because it's going to be a little slower. Because there's going to be a learning curve. Even if our doctors come to training, we do proficiency testing, we know that they know what they're doing, there's a lot involved. Doctor has to put in the order correctly. The order has to flow correctly. The nurse has to know where to look for it, or the clerk has to know where to look for it, the receptionist, the scheduler. Everyone's being affected by this go live. So clinic schedules are going to be reduced at the go live, and we can, if we're doing fine and everything's going great, we'll ramp up those schedules immediately within days. If not, we'll slow it down, and we'll keep it slow for 3 or 4 weeks as we get over that learning curve. Same thing with elective surgeries. Any of you that work in the perioperative areas, I can promise you, I've been to many go lives. Perioperative areas are the most complicated areas because there's a ton of handoffs and everything has to work just right. It's a complicated ballet, and if one person doesn't do exactly what they're supposed to do, the way they're supposed to do it, you might not catch the ballerina. So we're going to slow down our elective surgeries. I've had surgeons say, well, what about my emergency cases? Yeah, we could probably go forward with those. But elective surgeries, we're going to slow down during our go live. We're going to be bringing in outside help from Cerner and from other people, and we're going to be bringing inside help, which are our GLASS, our Go Live support staff. So they'll be there to help you. Those are your colleagues. They're going to be generally from your floor, your unit, your clinic. Next slide. I mentioned GLASS folks. They are going to be having extra training. So they're going to have the same training that you do, but they're going to have some extra training. They're going to be roaming through your training sessions. They're doing 2 things when they're roaming through your training sessions. You'll see them walking around. One, to help you if you get stuck. If we have a class of 30 people, it's going to be hard for the one trainer in the front of the room. My computer won't turn on. Yeah, we're going to have those Go Live folks around to help you with those things. The second thing they're doing is getting smarter than you. If you take a class 3 or 4 times, you're going to know it better than someone that took the class 1 time. So they're going to hear that information over and over. So they are really going to be Go Live support staff. Okay? And they also, I think, if you've signed up, you like a free T-shirt. It's often green and has a little Elmer logo on it. Next slide. I just wanted to hit this very quickly. Meaningful use, you might hear that term bandied around. You might hear people say, oh, we're doing CPOM for meaningful use. Not accurate. We're doing CPOM to improve the care of the patient. However, if someone wants to give us money, extra money, to help take care of the patient better, who are we to say no? Meaningful use is a government program. And it's there, just like I said that payers, insurance companies are trying to give us, incentivize us to do the right thing. What's the biggest payer in the country? Federal government, right? Medicare and Medicaid, biggest payer in the country. So this is their way of saying, hey, if you do this, we'll give you some extra money. If you don't do it, that's okay, that's cool, until 2015. In which case, we're going to start cutting you back by 1%. Meaning whatever you would have gotten, 1% less, which doesn't seem like a lot until you think about how much it is in the big picture, and it's a big number. So that's what meaningful use is. So if you hear that, that's what meaningful use is. That's why, and we are trying to get money from our meaningful use. We want to meaningfully use our electronic health record, right? But that's not why we're doing it. Next slide. And you can go to the next slide again, because I'm running out of time. I just wanted to really emphasize the movement there. And that's fine. So the previous slide was just there to tell you we're doing a ton of work. We've done a ton of work. There's still work to be done. We'll be doing work up to Go Live. Here's the last question. Which Elmer are you? This one, you guys, only half of you have answered this question. So which Elmer are you? Happy, sad, unsure, or what? And the answer is, let's see, this will be interesting. Oh, very nice. Half of you are happy, only a small number of you are sad, and about a quarter of you are unsure or what. All right, and the last slide is my contact information. There's my email address, there's my Twitter handle, there's my phone number. I throw that up there because I'm technically required to have a phone. It's a waste of your time because all that's going to happen is it's going to make a little voice file and it's going to go to my email. And I'm just going to answer it that way. So I don't know how, and in fact it's a little embarrassing, but I don't know how to take voicemail off my phone. I can take it off through my computer. So don't call me, just email me. And if any of you are really cool, you can come up and use your QR reader, and that'll actually give you my phone number. So I think we're almost out of time. Can I have 1 or 2 minutes? She's giving me the high sign. Any questions? I'm happy to take any questions. Wow. All right, everyone wants to, that guy in the back again. Yes, sir.
What happens to the physician that doesn't, just refuses to use this tool?
So the question from the unidentified man in the back is what happens to the physician who refuses to use this tool? Well, it's my job to convince him or her that this is the way to go, to offer them anything I can to help overcome their resistance. But ultimately, there is no other way to practice medicine at our organization. There is no alternative. There will be no one who says, who we give permission, oh, for you, no problem. You continue to write your paper orders. That's not our policy. There is no exception to this rule. So everyone, even for doctors that come infrequently, even for doctors who make threats and threaten to hold their breath, everyone's going to be doing CPOM. And so it's a train that's moving. So that's what's going to happen to those doctors. I assume that all of them will be convinced.
Doctors that can't type, for whatever reason, are we going to, is Agnesian hiring people to do all their orders?
So the question was, for those doctors that can't type, are we going to be hiring scribes or transcriptionists to do all the orders? The answer is no. We will be happy to work with them to help them improve their typing skills. However, most of the ordering will not involve typing, just like most of the use of the computer. Now, if you're typing in your order, Steve, you've probably made a mistake. You've probably made a mistake if you're typing in your order. Now, for your one-off orders and things that you do infrequently, sure, you're going to have to search. But for things that you're doing frequently, they should already be saved as favorites for you. For order sets that you do frequently, you should already have clicked most of the things that you're going to need to do. So typing is really a last resort. And no one's talking about getting rid of dictation. No one's talking about getting rid of the paper progress notes yet. I already told you that we're looking to get rid of paper, so we're going to be going in that direction ultimately. But typing is really not going to be a skill that's in high need for this phase of our project. All right, and I think that is it.
CPOM is my buddy. Yippee technology.